Welcome everybody to our Scale Neonatology Grand Round. For those of you who's the first time in joining, you're most welcome. We run these Grand Rounds every 2 months. We really try as a group to make sure we cover relevant topics, both for Uganda and for the UK. If there's burning topics that people have that you haven't heard us discuss before, please do get in touch and we'll try and accommodate them. Today, we're really excited to be discussing breastfeeding and breast milk, which, as we all know, is the best medicine for all of our babies. And what we do as a group is we rotate between the centers of excellence here in Uganda. And today we've selected the team from Mbarara to present to us. And then we partner with one of the institutions in the UK to join. So today we will have the team from Mbarara and a team from the UK presenting on that topic. So Scale Neonatology is a partnership between NHS UK, and which is the National Health Service in the UK, and then from Ministry of Health in Uganda. Start by introducing the team from Mbarara. So we've got Dr. Stella Kyoyagala, who is Paediatrician working in the neonatal unit in Mbarara University of Science and Technology. And she is joined by one of her postgraduates, Precious. Precious, apologies, I forgot your surname right now. It's fallen out of my head, but Precious will introduce herself. So they will take us through a case study and some discussion about breastfeeding and breast milk. And then we'll have time for questions at the end of that. I should also say, as well as having time for question and answer at the end, please go ahead and type any questions you have as we're going in the chat. And Dr. Kath from the UK and myself, Kathy, which I believe can be quite confusing here in Uganda, we will try our best to answer questions in the chat as we go through. Otherwise, you're all most welcome. And Stella and Precious, please go ahead and share your screen.
Okay, thank you so much. So in the outline, how to see that introduction, we shall look at physiology of breastfeeding, myths which are surrounding breastfeeding in Uganda. We shall also look at of breastfeeding and how to go about them. We shall look at the steps to breastfeeding and successful lactation, and then we shall have a few conclusive remarks. So in the case, our case is an infant, a 6-month-old infant who was born at term, and the mother had elective C-section from hospital. She had a birth weight of 3 kg and cried immediately after birth, was not resuscitated. So we shall give only the breastfeeding and nutrition history as it is our focus for this day. Yeah, so this mother initiated breastfeeding at the age of 12 hours of life, and the reason was that the mother was really so sleepy and wanted to actually rest after the C-section. So at 8 hours of life, as the mother was resting on a routine examination of the mother and baby, this baby was found weak with a reduced activity and convulsions. A random blood sugar was done on the baby, and the baby was found to be hypoglycemic with an LMNS of 1.6. She was admitted in the NICU and managed for hypoglycemia, and on the 5th day he had improved and was sent home. So the mother started breastfeeding at the 12th hour of life. She had enough breast milk there after, and she breastfed on demand at 8 episodes a day. In the course of the breastfeeding, this mother had issues and problems. What she remembered are the cracked nipples. However, even when she got them, she continued with the breastfeeding. To note for you, this this mother is a nurse. In the as we continue, it's important for us to know. So at 2 weeks of age, this baby had excessive crying, and the mother thought that she didn't have enough breast milk, so she introduced lacto infant formula, which she gave as she continued with the breastfeeding. However, at 4 months of age, this baby refused this infant formula that was introduced, and the mother started to feed on porridge. She would give it by cup, and then on some days would give it using her hand on the palm. Yeah, so she continued with breastfeeding and porridge, which went on up to 6 months when she introduced other feeds. Yeah, so at the moment the infant has mild iron deficiency anemia, which is being managed. So we shall look at the introduction and the first the definition. So and the first one is exclusive breastfeeding, which is a process of feeding a child on only human breast milk with no other feeds, which include liquids and solids or water, except for those medicines which have been prescribed in.
Precious, please continue. You're most welcome.
Thank you so much. So the next is the replacement feeding, and this looks at feeding a child who is not receiving any breast milk with a diet which provides all the nutrients which this baby needs until when they are fully on family foods. Then you will look through some of the other definitions. The other one to look at is weaning. Weaning is a process of introducing an infant to other foods as you reduce the supply of breast milk over it's done over a course of 1 month. And then prelactio feeding is giving newborn infants other food or drinks other than the breast milk, and it's something not good, as we shall see in the next in the presentation. Yes, let's go to the next slide. So we look at the global recommendations. So what we have here is the recommendation of World Health Organization and then UNICEF. Initiation of breastfeeding is recommended within 1 hour of birth, and this applies to all mothers. If it's a C-section or an SVD, these mothers are expected to have breastfed within 1 hour of life. And then they are supposed to breastfeed exclusively for the first 6 months of life, after which we are expected to introduce nutritionally adequate and safe feeds as we continue with breastfeeding to at least a minimum of 2 years or beyond, except for a few exceptions, which we shall look at later on. So from World Health Organization, it aims to achieve a 50% of breastfeeding at least by 2025. Yes, let's go to the next slide. So here we look at the different graphs which look at the trends of breastfeeding as per now, as compared to what is expected. Yeah, so we are at 46% globally of babies are breastfed within 1 hour of birth. And what we look at and the aim we have, our expectation is to at least have 70% of babies who are breastfed within 1 hour of life. And then 48% of babies are exclusively breastfed for the first 6 months, and still our target is 70%. As you can see, we've not yet achieved what we expect. Yes, and then we are at 71% of babies who are receiving breastfeeding up to the age of 1 year, of 1 year, which is still below what is expected for them. And then we've got only 45% of babies who are receiving breastfeeding up to the age of 2 years, which is still way beyond what we expect to have with them. And as you can see, as the babies go on, at the end of 2 years, we've got a smaller percentage from what we had at birth and what we had at 1 year of life for these babies. Let's go on to the next slide. So the trend here looks at what we've achieved globally. So as of 2023, we were at 48% of babies who are breastfed exclusively up to 6 months of age, and the target is supposed to be at least 50%. So we are not yet there, and that's why it's very important for us to have this teaching and practice it. Let's go to the next slide. So this is a map that looks at the different trends, what has increased in the countries really over the past in the past 5 years. And as you look at in Uganda on this map, we have not really had any increase in the past 1 decade in breastfeeding. And this is something that really, which calls us to act on this and find out what is happening, what is wrong, and implement more exclusive breastfeeding for these babies. Let's go on. So globally, still, we have looked at the country with the highest rates of breastfeeding, and it's found to be Croatia. Why it's highest in Croatia? We shall look at the different reasons why some of the countries have higher breastfeeding rates as compared to others. So after Croatia, we've got Switzerland, Netherlands, and for Africa, we've got Rwanda and Burundi. In Uganda, we are still low there. We haven't really reached in the high rates that we expect. Yes, and one of the different reasons why these countries have high breastfeeding rates is attributed to longer lives for these mothers after birth. Like an example, in Rwanda, they have a maternity leave of 6 months, which is paid, and then then it's also attributed to a ban against other breast milk supplements and replacements. Yeah, it's rare to get them, and they are very expensive once you actually get them. Yes, let's go on to the next slide. Yes, so we also looked at one that has the lowest rates of breastfeeding, but we didn't find its reasons as yet. So as of Uganda, we are at 62% of our babies, and they're breastfed exclusively up to the age of 6 months. And we have not had really any marked improvement in the past in 10 years in advancing this breastfeeding. And the reasons which are given for this little advancement in breastfeeding is maternal age. So we are in a study which was done in 2022. It found out that younger mothers it found out that older mothers who attended antenatal more and were residing in rural settings were more likely to have exclusive breastfeeding as compared to younger mothers who did not attend antenatal or who attended less antenatal care and are in the urban residents. Let's go to the next slide. So what is different with these in the countries that are doing better with breastfeeding? So these countries have increased funding to actually raise breastfeeding rates from birth up to the age of 2 years. And then this also implement a code of marketing for these breast milk substitutes, which include formula. Yeah, you see as of in Uganda, this formula is everywhere, and it's being made more affordable. So this is something that really reduces on our rates of breastfeeding, which we should work on and try to encourage breastfeeding more in these mothers. Then these countries also are able to enact a paid family leave, which is longer as compared to what we have in those countries that have a less rates of breastfeeding. We have also workplace in the workplaces in these countries. It's more favorable, and they have different breastfeeding rooms, and this allows mothers who are breastfeeding to even go on and work as they breastfeed. Then they also implement our 10 steps of successful breastfeeding, as we shall see them later on. Yes, let's go to the next slide. Yes, and then they also have improved access to skilled breastfeeding and counseling. These mothers in those countries are able to be aided right from birth and then through breastfeeding. Even when they get a problem, it's easier to know who is whom they can approach, where to go, and the policies are more streamlined. Then there are also strengthened links between health hospitals and the communities of these mothers where they live. Yes, and then there are also other systems that track the progress of policies and funding for this breastfeeding in these countries. And then there is increased support of infant and young child feeding in emergency settings for these mothers. We can go to the next slide. Yeah, thank you so much. I end here.
For that wonderful insight, and I hope as we listen to the presentation of today and get to practice, we will improve, we'll be part of the people improving the statistics of breastfeeding. So just a quick look at the physiology. One is that every mother who is pregnant, as we get towards term, second trimester and third trimester, start producing breast milk naturally, and even if the baby is born anywhere between 24 weeks onwards, whether they continue breastfeeding or not, they'll be able to have breast milk. So that means we'll be able to produce breast milk even for premature. And next after birth, you have the mother removing the placenta and allowing this hormone of the breast milk. And
Dr. Stella, I think we've lost you. We were hearing Precious very clearly, but we're not hearing anything now.
Okay, and can I be heard now?
Yeah, are you sitting in a different position to Precious? Because we could hear her very clearly, but you're a little bit breaking up.
I'm in exactly the same position.
Oh, maybe you need to sit on her lap. Try again and we see.
Okay.
No, that's better. Just come a bit closer. We can hear you really well now. Go ahead.
Okay, thank you. So the two important hormones of breastfeeding that are produced after birth are prolactin, a hormone that is that helps to produce the breast milk that will be used by the baby and stored in the breasts. And then the oxytocin helps us to release that milk out of the breast so that the baby can be able to take it. Next slide. One important thing to note is that the prolactin is released all through as long as the baby is stimulating the breast, but most of it is released at night while the baby is sleeping. So with after birth, we start producing the breast milk, and the real first breast milk we get is colostrum, which is produced in the first 2 to 5 days, and then some mothers who delay to move on go up to 7 days. It is the best milk. It is rich in nutrients that help to protect the baby against infections. Alpha IgA protects the baby's gut, and also act as a lubricant because it has a lot of fat to help the baby pass meconium. However, if you give prelactal feeds, things like sugar water and other milk, types of milk to this baby during the period of prelactal feeding, you inhibit the production of colostrum, and once you interfere with the production of colostrum, most mothers will not succeed with having enough breast milk later. But also, if you give them concurrently with the colostrum, they interfere with the functioning of the colostrum. So we should let mothers to have that colostrum produced without any other interference. Next slide. And I wanted to emphasize this this picture for people to see that colostrum can be in different colors on different days. And in the beginning days, it may start out with different colors of brownish. And when mothers tend to express, they keep thinking that this is dirty milk, and everyone will want to pour it away. And also some health workers are confused in between whether the mother is bleeding from the breasts or not. So I just want to reemphasize that colostrum is usually richly yellow in color in the first days, but it can also go to the ends of brown and to the ends of pale white. So we need to reassure them that this is the normal milk and this is how it can look like in other mothers, and there's no need to worry or withdraw the breastfeeding. Next slide, please. So in the mature milk, we have the formula, which comes first as the baby is starting to breastfeed. And the mature milk comes after the colostrum, and usually it comes in large volumes. One thing I forgot to say is that the colostrum is produced in very small volumes, and it comes in about 40 to 50 mils, maximum 70 mils. And so if you have a baby breastfeeding 2 hourly, that may be like 3 to 4 mils. So mothers should never feel like they do not have enough milk in the first days when they are having colostrum, because the body is made in a way that it produces little but very concentrated milk, and also that colostrum has high sugar, so the baby will never go hungry or hypoglycemic on that colostrum. Whereas the mature milk is produced in very large volumes. Now the mother who was complaining that she has no milk, she will now start having too much milk, and she'll start complaining that it's too much, the breasts are paining. So that is the mature milk. And every mother should start having it between 5 and 7 days. The forward milk is the first part as the baby is breastfeeding. It's usually a bit thinner and watery, but it's rich in proteins and water, which quenches the baby's thirst during breastfeeding. Hence, all our babies below 6 months do not need any additional water to the breast milk, because the first part they get is actually a lot of water. Whereas the hind milk is what is got at the end as the baby is breastfeeding. So as the breast is starting to empty, the hind milk will come, and this has a lot of fat. It's thicker, it's quite more white and a bit yellow, and this contains enough fat to help provide carbohydrates for this baby to gain adequate weight. So as we breastfeed, we need to remember that the baby needs to get all these 2 parts of breast milk. So let the baby breastfeed on one side until the breast is fully empty, so that she'll get the water, the proteins for brain development, and the fats for weight gain. Otherwise, if you breastfeed on the formula milk, you have a bright baby who is not really growing or having advances in weight. Next slide. So that is just a picture show the differences. The first picture shows you the forward milk, and the other one is the hind milk, which is thicker. Next. And then we all know the benefits of breastfeeding, but just to re-emphasize that to the baby, it allows normal growth without increasing chances of obesity and malnutrition as well, undernutrition, but also it allows normal digestion. And also this breast milk comes already with this digestive enzymes, digestive juices, and broken down components that it absorbs, as opposed to other milk products and formula which needs to be broken down. And at that time, the baby's gut is not ready to deal with excessive digestion. And it also optimizes brain development and intelligence. Babies who breastfeed have higher IQ than babies who do not. But it also reduces the chances of allergic reactions, because cow milk protein induces allergenic reactions, and these babies can cross over with these allergies into diabetes as a result of injury to the pancreas out of this allergic induction. And then because breast milk induces frequent stooling and lubrication of the gut, the chances of jaundice going to the extremes in terms of physiological jaundice are less. And then it protects the children against chronic diseases. So things like hypertension, diabetes later, and coronary artery diseases are reduced among those who breastfeed exclusively. Whereas to the mother, the oxytocin improves uterine contraction, hence reduces risks of postpartum hemorrhage. And then it makes the mothers burn extra calories. Every time you breastfeed, the mother burns up to 500 calories, and hence they will have faster weight loss after after pregnancy, after delivery, if they breastfeed. It's safe, it's economic, because you're not going to be buying 2 formula milk bottles every week of around 100,000 in Uganda. And also it protects the mother from certain cancers like ovarian and breast cancers. And then there's assured family planning for 4 months if that mother is breastfeeding at least 8 times a day regularly, both during day and night. So if you're not consistent with the times of breastfeeding, then the family planning may not be assured. And the bonding babies and mothers get from breastfeeding is for life, and it creates a unity in the family. Next slide. And so looking at all that physiology, now we want to look at the challenges that mothers face. You can realize from the case that was presented that we had also a health worker who struggled with breastfeeding. So it doesn't mean that health workers don't need support as well, but this puts the child at risk of being admitted, getting infections, and now has been readmitted again with infections because we didn't do our good breastfeeding. So one of the common problems that mothers will complain about is little or no lactation. So here, some mothers will have a bit of delayed moving on to mature milk, which some mothers may go 5 days, 7 days. And so they'll produce this little colostrum for a long time. And whereas others will totally fail to produce much of the breast milk. So the problem is that mothers with little milk are likely going to have challenges with their babies, as we shall see in the next slide. But also it can lead to dehydration in the baby, and mostly hypernatremic dehydration, which may cause brain injury. Next slide. So most of the causes usually is if there is no milk breast stimulation. So if you don't put the baby on the breast cycle, you won't stimulate, and the mother is less likely to have enough breast milk. And also if you delay to initiate breastfeeding, if you take more than an hour, the chances that that mother is going to struggle with getting breast milk are high. And also if you start adding on other things to the breastfeeding, because we assume that because we are having colostrum, the mother is not having enough milk. So this makes, once you start adding in water, formula milk, you interrupt with the breast milk supply. And then babies who have problems, like those who are tired, birth asphyxia, prematures, cleft lip, they may not suckle well, and this may lead to reduced milk production. And then mothers who had breast surgery and took away most of the breast tissue, retained placenta that will keep the hormones that interfere with breastfeeding persisting. And then many other problems, but also mothers who get severe PPH, they may get Sheehan syndrome that may interfere with the production of hormones from the pituitary gland. Next. So for a mother not having enough breast milk, this is what will usually happen. The baby will want to breastfeed so many times. The mother will not feel that milk let down. As the oxytocin is being released during breastfeeding, they are supposed to feel the contraction in their breast and the release of milk and flowing of milk from one side and the other. And then they won't lick breast milk. Their breast will remain soft for a long time. The baby will not be settled on the breast, and sometimes they get frustrated and give up on breastfeeding. And then the baby keeps sucking on hands all the time. And then the mother who is working, when they don't have enough milk, every time they try to express, they may not even be able to get a bottle. And then the baby will not have adequate sleep. So as we are assessing for adequacy of breast milk supply, let's ask all these questions. If they are present, it means this mother will need more help to get more milk. Next. So what do we do for such a situation? One, you need to reassure the mother. Some mothers have a mentality that they will never produce enough milk for their baby. That is not true. Every mother is capable of producing enough breast milk. So we should help them to have enough sleep at night, to produce enough prolactin, drink plenty of hot drinks, and then breastfeed frequently, at least 2 hourly. Once they are having this breastfeeding problem, we cannot wait for 3 hours. It's better to do it frequently. And then they need to eat enough food and take enough hot drinks to help in oxytocin release. But also they need to ensure that they are emptying both sides of the breast to help them get more breast. Once their breasts are full, they usually turn off the stimulation reflex to the brain to produce more milk. But also look for underlying problems and depression and all these problems and support the mother better. Giving galactose, especially metoclopramide, galactovit, this is last option, and more than 90% of the mothers will respond to only those above mentioned interventions before they need drugs. Next slide. The other problem is express milk supply. Their mothers who get too much breast milk. And I always tell them that for me, this is not a problem, and we need to reassure them. Whoever has excess can express some and donate more to others. But those who are not able to do that, the problem is that they'll feel their breasts are paining all the time and they are too full, and then the baby may not be able to attach very well on such a full breast. So what we do, we encourage them to offer one breast at a time and ensure that they empty it. But also they can wear some bras to reduce on the feeling of the breasts and take some cold drinks in between. However, most of us are looking out for this milk for those who have extra. So where we have breast milk banks, we could use this chance to help other babies. Next. The other problem is mastitis, where the breast is inflamed and hot and painful. Next slide. And this comes usually from a much engorgement. And the biggest problem with this is that the mother will feel too much pain and may not want to breastfeed. Once there is mastitis, let us help the mother to express the milk out so that the blockage reduces, and also apply some warm compress. And if there is a fever, the mother can try and take some painkillers and antibiotics. Next. And so this is a summary of what to do. One thing everyone needs to remember, that even when a mother has mastitis, they must breastfeed, breastfeed, breastfeed. And breastfeeding is the biggest treatment for their mastitis. So let us emphasize that they need to breastfeed. And then we can do a bit of massage to ensure that the breast empties, and also warm and cold compress. If those don't work within 24 hours, let her see a doctor. Sometimes there may be an infection setting in. Thank you. Next. And the other one is cracked nipples. As we saw in our case presentation, cracked nipples and sore nipples, they are so painful, and yet they are so common. Most mothers in the first week are going to get this, because as the babies try to breastfeed, initially they use a lot of pressure to open up those ducts. Next slide. But also it's because some babies do not attach so well. So the common causes is poor positioning and poor latching on the nipple, and then mothers who have either too much engorged breasts or too little. And so we need to kind of help them in the management to reduce on these challenges that may cause cracked nipples. And the other thing is, when mothers keep pulling the breast out when the baby is still sucking, it creates a lot of pressure trying to withdraw it. So it's better let the baby suck until they are done and let go of the nipple. Next slide. And in the management is to try and avoid engorged breast and help mothers to get enough breast milk for those who are having no breast milk, and then ensure good attachment. And one thing is that you need to reassure these mothers, after as they are breastfeeding, let them start on the less painful side and then go to the painful side. The babies will not have too much pressure they are applying by the time they have taken some milk on the other side. And then you can apply, after breastfeeding, you can apply the last breast milk on the nipple to moisturize it and reduce on the cracking, or apply some nipple creams. And reassure these mothers that usually after the first week, the baby has learned to breastfeed, the pain will go away and the ulcer will go away. Next slide. And the other one is having babies who prefer one side of the breast, or mothers who prefer to give the baby one breast and leave out the other. So this is usually because the baby prefers to be in a certain position, and sometimes because the mother prefers to favor one breast. Every breast is good and is capable of producing enough milk for the baby. And what we can do for such a situation, that always start with that breast that you assume that the baby doesn't like. Give it and try to encourage the baby to accept it and give it time. Do not just put for 1 second and say the baby has refused, then you change. And also, if the baby sometimes refuses, try and pump that side to help it get more breast milk after the baby has fed on the other side. But please, it's always good to allow the baby to take on both breast milk. And the other problem is mothers who have multiple babies, twins, triplets, quadruplets. And next slide. This should not be a challenge. Each mother is capable of producing enough milk for the babies they have. And the more these babies breastfeed, the more milk they will get. I've had a mother with quadruplets that we've supported through exclusive breastfeeding, and she did it for 4 good months, exclusive breastfeeding of 4 babies, and their babies were bigger than my 1 baby, who was also healthy. So it goes to show us that the more babies you have, you're able to actually produce enough breast milk for them. Just let them be able to breastfeed adequately, 1, 2 babies at a time, and also to ensure that they get both parts of the breast milk, the foremilk and the hind milk. And next. And lastly, as I conclude, I wanted to bring back some of these myths that we need to overcome as we support mothers. One is that mothers think colostrum is dirty and not good for the baby. We've already seen that it's the best. It's every baby who misses out on colostrum misses out on an immunity for the rest of their life. So let's give them this. Colostrum, as we said, can be in different colors. Relactio feeds, please, they are not necessary. It's not good to give anything else other than breast milk in the first days after delivery to allow them to even get more milk later. And then breastfeeding can contribute to child weakness. It's not true at all. Breast milk is even helpful in protecting children against getting sick. And then that's not to breastfeed while pregnant. Some mothers will conceive like 3 months after delivering. If you conceive within a short time when you're still breastfeeding, please continue with your breastfeeding. That breast milk will still have the same good content and it helps to protect the babies the same way. What we need to see is that the mother gets enough nutrition during this time. And that relactation is bad for a child is not true. Sometimes we get mothers who are stopped some time back. When they come to us, if they are below 1 year, the baby is less than a year, let's ensure that we put that baby back to breastfeeding, and it's so beneficial for the baby and the mother. And then mothers who say that beer and Coke increase breast milk flow is not extremely true. And beer and Coke So thank you for listening to us. I guess because of time, we'll have to stop here to allow our colleagues from the UK to have a presentation as well.
Amazing. Thank you so much, Dr. Precious, Dr. Stella. If people want to send flowers, smiley faces, greetings in the chat, please do. In the interest of time, and I realize we've had quite a few technical issues, and apologies for that, we will try between us to enter as many answers in the chat box as possible. We're going to move on to the next presentation. And if we still have a little bit of time at the end, we will open the floor to questions. So once again, huge appreciation to Stella and Precious for a fantastic presentation, taking us from global right down to the myths and challenges of breastfeeding locally here. So huge thanks from me, guys. I have the pleasure of introducing Abby Cooper, who is a breastfeeding advisor working in the UK. So Abby, you're most welcome. Please go ahead and share your screen.
So yeah, my name's Abby, and I've come to talk about the lactation and the mother. So to begin with, I'd like you all just to imagine what a baby goes through when they've just been born, whether it's via cesarean or whether it's a normal vaginal delivery, the environment that they've come from and the environment that they're now presented with, and how we're going to try and eventually comfort them by keeping them with the mother and providing them with colostrum. So to begin with, I'm going to talk about lactation, and the process is called lactogenesis. There's 3 stages to lactation, and the whole process is called lactogenesis. So it's made up of 3 stages, and stage 1 begins in pregnancy around 16 weeks, and it can last until a few days after birth. So during this time, estrogen and progesterone hormones rise, causing the milk ducts to grow in number and size. And then the breasts become fuller and the mammary glands prepare for milk production. The nipples become darker and the areolas become larger. And going back to the baby, that's so that the baby can make its way, if it's in skin to skin, that baby can make its way to the breast by recognizing this nipple and areola, which is larger and darker. And then your body begins to make colostrum. So that's stage 1. No, we've got another 2 stages. And then stage 2 starts around 2 to 3 days after giving birth, so postpartum. And the milk production intensifies at this time. So when the baby is born and the placenta has been delivered, the estrogen and the progesterone levels then begin to drop and prolactin takes over. And prolactin is the hormone needed for milk production. And then finally, stage 3 is the rest of the time that you lactate. So lactation continues for as long as the milk is being removed from the breast. Next. And then just to go back there, lactation is a supply and demand process. So whether you are hand expressing, whether you are using an electric pump, or whether the baby is there to breastfeed, then it is a supply and demand process. So the more we ask for, hopefully, the more we're going to produce. And then moving on to colostrum. So colostrum is the first milk that the body produces during pregnancy. And it is referred to as liquid gold. And I've put that in capital letters just to emphasize the how amazing colostrum is for babies. It's referred to as liquid gold due to its rich yellow colour and its high nutritional value. And then colostrum has nutrients and antibodies which will fight infection and protect the baby. And colostrum changes around 3 to 4 days after giving birth. And then just to share with you that preterm babies are at risk of developing a condition called necrotizing enterocolitis, which is also known as NEC, N-E-C. And the studies have shown that there is a lower incidence of NEC in babies receiving colostrum or breast milk compared to babies receiving formula. So we really, really encourage our mummies on the neonatal unit to start expressing as early as possible so that we can offer the babies the colostrum. So on this slide, I have I've discussed how to hand express. I would have loved to have put a little video up, but I've not had a chance to do that. But often on the neonatal unit, we would use a doll and a breast, and we would show the mum how to hand express. There are many benefits to hand expressing antenatally. It allows you to become familiar with your breast. And being able to express colostrum if the baby was to have difficulty feeding, and if the baby is born early and is admitted to the neonatal unit, obviously if the mother has had experience hand expressing, this is all good for moving forward. And it also helps to avoid becoming engorged and mastitis, which often around 2 to 3 days, your breasts are full and you often feel engorged. So here on our neonatal unit, we do really encourage the mums to hand express. It can be really difficult after giving birth because you're tired, you may feel unwell, but yeah, we really encourage mummies to hand express as soon as possible. And then moving on to skin to skin. There are many benefits of skin to skin contact, and we recommend skin to skin contact as soon as the baby's born, for as long as possible, uninterrupted, definitely for up to 1 hour following birth. And then we often, when babies are born by cesarean section, often the women don't get the opportunity to have skin to skin. So that's something that we're really trying to work on to ensure that these mums that have had cesareans have skin to skin with the mother. And if this isn't possible, then maybe dad could have skin to skin with the baby as well. And then, yeah, lots of benefits of skin to skin. I've just documented a few there. That it regulates the baby's heart rate, the breathing, the temperature, and then linking it with lactation, it stimulates digestion and supports breastfeeding by releasing the hormone oxytocin. And then, yeah, and it also enables colonization of the baby's skin with mother's friendly bacteria, providing protection against infection. Whilst the baby's in skin to skin, often they'll start giving cues to feeding. So they might start kind of working the way to the breast. They may start head bobbing. They may start bringing their hands up to the mouths and mouthing. So all these cues are really good to for mum to become familiar with the feeding cues later. And then moving on to lactation and prematurity. So if a baby is born prematurely, it may be that they're not ready to breastfeed. So we would encourage the mother to start hand expressing as soon as possible, and definitely within the first 6 hours of giving birth. The colostrum that mum provides can be used just as mouth care for the baby, whether that's for comfort or to obviously for all them benefits that we've discussed, or it can be given via a nasogastric tube, which a lot of our babies on the neonatal unit, and that's how it would be given, you know, over a couple of days, but initially we would give it as a buccal. And then from there, we would encourage regular skin to skin, and then we would move the mum from hand expressing to use an electric pump, which again can be quite difficult for the mum to want to use the electric pump. And we encourage that she uses the pump maybe 8 to 12 times in 24 hours. So that's very demanding for the mother, especially if she's feeling unwell and is in the hospital setting. And then in some cases, the milk that she provides, which she's expressed, we may need to add fortifier, which is extra vitamins and minerals. It comes in a powdered form, which we just add to the milk. Often babies that aren't gaining weight might start on fortifier. Yeah, I'm just saying about going back to how difficult it can be for the mother to express, especially when the mother and baby have been separated and she's at home. And then, yeah, finally for this slide, for the extremely preterm babies, here on our neonatal unit, we have a milk bank. So other mothers can donate their breast milk, and then it gets pasteurised and it gets frozen, and then we can use that for our preterm babies. we also send it to other hospitals locally so that they can also have the benefits of somebody else's breast milk. And then just some discussion points here that we've already gone through, but just if there's any questions at the end. The benefits of colostrum, skin to skin and breastfeeding are endless. And with guidance, support and reassurance, it is possible for any mother, whether they've had a preterm baby or they've had a normal delivery, that it is possible with all the help that is offered to them. There are many websites available, and just to quickly talk about baby friendly, the UNICEF baby friendly accreditation, which I think you talked about on your presentation just before, the 10 steps to successful breastfeeding. There's lots and lots of information out there online that we can all access to help these families. And yeah, just to say that I'm very passionate about helping women and their babies to have the best start possible to bonding and breastfeeding. And I think that having listened to the last presentation, you all feel the same, and we should all work together to enable these babies to have the best start to life. I think that's it. Thank you for listening, and I hope there's some questions at the end that we can answer for you.
Amazing, Abby. Thank you very much. Huge appreciation for me for sharing your experience and your knowledge with everybody. So please, everyone, show your appreciation in the chat. I didn't see any flowers last time. I'd like to see lots of bunches of flowers coming in there this time. I just wanted, before we open for questions, I've been trying to keep up with the questions in the chat box. There's a few that I'm going to pass over to Abby with her expertise in beautiful flowers. Thank you, everybody. Expertise in breastfeeding. A couple of things I've put in the chat just in case people didn't see. So for me personally, I'm part of the NeoNUNet, which is a sub-Saharan Africa neonatal nutrition network. And over the last year or two, we have developed a neonatal nutrition online course, which I've put the link in the chat. And Jeanette, maybe we can share it out on email afterwards. It's free. It's designed for our setting. It's relatively basic, but I encourage all of you to undertake that course and get some more training in neonatal nutrition. And then the other thing, as much as it's great to teach expression on the mother herself, if you want to do a training session, perhaps on the ward or with your fellow healthcare workers, it's perhaps not so appropriate to strip down the mother naked and teach on her. I've put in the chat as well. Calderdale Global Health, that's the one that makes our upright amber bags here in Uganda. They also make some beautiful fake purple breasts that you can fill with water, have a little bit of fun with, especially if you've got gentlemen in your teaching session, but they're really great for teaching the techniques of milk expression to your fellow colleagues and people around you. So there's so many flowers in the chat. I believe these flowers are now for Abby, for Precious, and for Stella. So now I have to jump all the way back past all your flowers to find all the questions. Abby, I don't know, there were a few questions in there. There's one that Justin has asked, and the mother who has had sore nipples for over 4 weeks, and she's had some practical support sessions, but she's still got sore nipples. And there's a couple of similar questions about cracked nipples in there. I wonder what your advice would be, Abby, for these mothers who have got sore or cracked nipples, how to overcome that and what our colleagues can do. Thank you.
Thank you. So usually cracked nipples would be due to poor positioning and attachment. But like you've just said, it sounds like they've already had some support, but I would probably go back to looking at the position of the baby. Sometimes changing the position completely. So if the baby's being fed in a cradle position, maybe they could be moved around to the rugby ball position, and that might relieve a certain area of that cracked nipple. So definitely positioning and attachment. If it's a long-term thing, we would probably look at the possibility of a tongue tie. And
yeah, that was another question. So maybe you just want to move into that, Abby. Someone had asked about what can be done for tongue tie.
So here we they would be referred to the ear, nose and throat specialists or to a lactation consultant who would have a look at the mouth and assess whether the baby's got a tongue tie or not. They'd also assess a breastfeed as well, and then decide whether the tongue tie is affecting the latch. And then they either would divide the tongue tie and then provide ongoing support with breastfeeding, or it may be that they'll just observe for the next couple of weeks to see how that goes. But yeah, for cracked nipples, to soothe them, we used to use a lot of creams, but now we just say to express a little bit of milk and just kind of dab it around the area to bring some relief. But it's difficult when, you know, when your breasts have never been used for such thing before. They are very sensitive and it's very difficult.
And then Abby, do you mind just to add something about breastfeeding when you've got an abscess and what should be done during that time? There's been a few questions about that. If not, maybe even Stella, you had mentioned it. I mean, essentially these mothers, if they've got a problem with the breast, they need to carry on taking the milk out of the breast. If the milk stays in the breast, the pressure is going to make the pain worse. We can still breastfeed in the presence of mastitis, in the presence of an abscess. If it's unbearably painful to breastfeed, we can try and support the mother to express her milk to try and get that milk out. But the milk is still safe for the baby. So we should never stop feeding, fearing that the milk is not safe for that baby. Maybe Stella or Abby, if there's anything you wanted to add.
I think you've covered everything there. I would definitely recommend massaging where the abscess is. Just keep massaging it to kind of free up that milk, and yet continue to breastfeed. And yeah, if it was ongoing, then just to seek further medical help. Like you say, it's very painful, it's uncomfortable. So yeah, I think you covered everything there, definitely.
Thanks, Abby. And then I just wanted to mention, Abby talked quite a lot about electric pumps. So there's two different kinds of pumps. There's ones you can just buy in the supermarket, and they are available here in Uganda, but there's also something called a hospital grade pump. And the difference is the ability of the milk to go back into the pump. So a hospital grade pump doesn't allow transmission of infections between patients, but the ones that we can buy in the supermarket here in Uganda shouldn't be utilized between two mothers or two babies. So it means that currently in Uganda, at least for most of us, it's not safe or possible to use those electric pumps. So really, for those of us working here, I would highly encourage you just to focus on hand expression, which once you get good at it, is actually a really fantastic technique. And obviously, even if power goes off, your hand still works. So for us, where we don't have reliable power, it's probably a much more suitable technique. So just to bear that in mind, maybe one day we'll catch up with you, Abby, and we'll have those hospital grade pumps, but just to be careful with those. There's a couple more questions come down here. I think we'll just answer them in the last few minutes. There's one from Sharon. If a baby has been detached from its mother for about a month because of medical reasons, how can we support the mother in milk production? So I don't know who would like to take that. That's about how to help a mother relactate. And I think just to add on to that question, it's really key because we don't want to take this baby straight to formula milk or send them to the malnutrition unit and start them on F75 or whatever, because it's not sustainable. So really, relactation, as you've said, Sharon, is key to making this sustainable and not ending up back in hospital with malnutrition 2-3 months down the line. So I don't know who wants to take that question about supporting methods for relactation.
Relactation after a month, I've not come across, but I would probably just recommend going right back to basics with the skin to skin and the regular hand expression, and obviously trying to put the baby to the breast to release that oxytocin for the milk to come in. But yeah, a month is a long time, but it is possible. And there's lots of guidance out there on you know, on the website, such as the BFI and La Leche League.
Great, thanks. And I think maybe from our side, it's also really important, formula is really expensive. If these mothers can't breastfeed, they often opt for cow's milk or posho or whatever they can find. We have done it, Abby, here, and it takes a lot of time and effort. We have had quite a bit of success here, although I realize some people asked in the chat earlier, domperidone doesn't have success for everybody, but it's worth trying oral domperidone to try and support improved milk production. So that's 10 milligrams 3 times a day. And I'd give it a try for 1 to 2 weeks to see if it helps that milk supply to come in. But yeah, expressing skin to skin breastfeeding, and hopefully you can get that milk supply back up. And in the meantime, if you have access to a milk bank, you can use screen pasteurized donor human milk, or if you really need to, then formula milk. Great. We're running out of time, but there's a few questions in here. I think this one, maybe I can give this back to you, Stella, if you've got a good network now. What is the best advice given to mothers with HIV about breastfeeding? I think that's a really great question. Stella, do you want to take that? Stella, let me jump in. So all our mothers in Uganda should be on B+. So they should all be on HART, and the baby should be on nevirapine, in which case, actually, it's much better for the growth and the long-term survival of our babies to use breast milk. And so we know that it reduces mortality, both through reducing the diarrhea and the pneumonia, and also helping the babies to thrive. So we should still be focusing on breast milk. If you come across a mother whose serious status was not known until birth, get her on her HART as soon as possible and start the baby on nevirapine. If her viral load is really high and you have access to donor human milk, you can opt for that. But really still breast milk is what we need for these babies, and not jumping to formula milk. Yeah, I think that's it. Fantastic. I think we've tried to answer most of the questions in the chat. Apologies if I missed yours in amongst all of the flowers. I'm going to say a few words, hand over to Kath just to close. A huge appreciation to Dr. Stella, Dr. Precious, and to Abby for joining us today and giving us such fantastic presentations. Jeanette has shared the PowerPoints already, but I believe she's going to share that link to the online African Neonate Nutrition course for people who have more interest to have a look at. Otherwise, we really would appreciate your feedback in the post grand round link that will be sent to you or has already been sent to you. Otherwise, we'll be in touch with all of you almost 2 months from now with the next topic. And like I said earlier, if there's topics you really think we should be covering and we haven't, please drop us an email, or for those in Uganda, you're very welcome to send me a WhatsApp, and we can try and see how we can squeeze those in to our program. So thank you very much for attending. Kath, I'll just hand over to you to close, if that's all right, if your voice is there.
Just agree. Thank you to Pam, to Abby, to Stella, and for Precious. Amazing presentations, and really good just to share our learning between Uganda and West Yorkshire in the UK. So we are sending out a questionnaire, so just please fill that in. Let us know if there's any topics. The next date for the meetings on the 21st of June, and we'll be emailing out with the topics. And again, it will be the same format. So Uganda with a case presentation and some up-to-date sort of publications and guidelines, and the same from one of our teams in West Yorkshire over here in the UK. So yeah, and thank you to Jeanette and Tim for supporting and admin support. It's great. We've had over 110 people at one point online, which is a fantastic attendance, and I think we all learn from everybody. So it's great to be part of this scale team. So thank you very much.